Welcome to Making Medi-Cal Managed Care Work. For those that don't know me, I'm James Mason. I'm the President and CEO of SynerMed. We manage 800,000 lives in the state of California, and principally in the Medicaid managed care space. Is that a little bit louder for you guys? Better? All right, great, wonderful. I'm joined by two colleagues that I've had a lot of respect for many, many years. They've played active roles in many of the trade associations, key spots in the Medi-Cal subcommittee, etc. Megan North, she's the president of Conifer Health Systems, value-based care business line. Ms. North leads a national team of healthcare transformational experts that promote and provide clinical integration, population health management, and financial risk management for more than 300 Conifer Health clients in 20 states. She brings more than 20 years of experience to her role as she's earned a reputation for creating risk-based care delivery models that successfully align hospitals and physicians. These models, originally developed for the state of California, are now adopted as a nationwide best practice for providers ranging from large health systems to independent associations. So thank you for joining us. And also, Kathy Hegstrom joins us. Please stand. Kathy Hegstrom is the president of Advanced Medical Management, and she and her husband Stephen formed the company back in 1981. So she's been developing these type of programs since the beginning, and she's been part of the executive team since that creation. Kathy is involved in the operations of her company. She particularly enjoys reviewing claims and case management information. So she's a real policy wonk as well. Because of her interest in the cultural differences of healthcare delivery, AMM specializes in cultural niche groups and is a major part of their client base. She has an undergraduate degree in anthropology. I didn't know that. That's wonderful. And a master's in healthcare administration from Cal State Long Beach. She's on the advisory board of the Healthcare Administration Department, and she is the chair of CAPG State Programs Committee. So the current Medi-Cal program chair is right here. So thank you very much. We're going to do a little bit of a theme here. We decided that Medi-Cal's going through such a transformation, and this transformation has so many different ways about it. We've decided to do a little bit of a Game of Thrones feature here. So really what you have here is the Khaleesi, Megan North, right? So you'll be the Khaleesi, and we got Melisandre. She actually dressed apart, and I am Tyrion, the dwarf, which I don't need to dress apart because I am the dwarf. So let's see if we can get this thing to work here. All right, so there's an old Chinese proverb. If you guys are familiar with Chinese proverbs, it's been adapted a little bit for this presentation. If you plan for a year, plant some rice. If you plan for 10 years, plant trees. And if you plan for 100 years, educate. And so we hope that this process, not only do we provide some education, but we also really want to hear from you. I wanted to talk a little bit about, who's in the room so that we can get a sense of what's happening. How many here are not currently in Medicaid or Medi-Cal, Medicaid if you're in a different state, but are interested in getting into it? Okay, wonderful. God bless you. Hopefully we won't scare you away. And then those that are in Medicaid, that would be the rest of you, so you don't need to raise your hands. I'd be interested to know who are in integrated delivery systems. Hospital, group, integrated delivery systems, okay. Wonderful. And then how many are just hospitals? Okay, so everybody else is provider groups. Are there any health plan representatives in the house? Okay, all right, I got this. We'll try to be nice. we do love you. Yeah. So the Game of Thrones, the theme is because we really believe that the theme that's in the show is winter is coming. And one of the CAPG colleagues, I didn't get permission to use his name, so I'll just paraphrase him and not use his name, said, I think this might be either the best time ever to get in the business or the best time to get out of the business. And so that really inspired me to think, okay, so, what's going to happen? How's this going to play itself out? The good news is you don't have to worry about losing your head like Mr. Stark did over here. So we've got a couple guides for you to navigate the Game of Thrones. We've got our Khaleesi and our Melisandre. And as I said before, unfortunately, you've got me. I'm Friday here.
It looks just like
it. It does, kind of. A star red. One second, please. So the agenda is going to be, I want both Kathy and Megan to talk a little bit about the organization. We'll talk about SynerMed as well. And then we're going to talk about the current state of affairs of the Medicaid system. And then hopefully we'll get lots of questions and answers, questions from the audience about what you're going through and the like, so we can provide a much more dynamic and interactive environment. So with that, we're going to invite Kathy up. And there's a big latency in the button here.
So do I just push the forward button?
Yeah.
Okay. So I'm from Advanced Medical Management, as James told you. We're an MSO. We've actually been in business since 1981, but we really became a true MSO in about 1992 or so. Before that, we were a small practice in actually the very now famous city of Bell. And we actually had the PHP line of business back then, where you got a monthly payment for CAP for the primary care. And I was telling James, I don't remember actually what we had to do to send patients for specialty care or anything like that, but it was all taken, we weren't at risk for any of that. And so you can see how things have changed totally. And then all of a sudden we were with UHP and had to figure out how to deal with all of these different things, but really we had pregnant women and babies, and so if we had an OB clinic and an immunization clinic and somebody who knew about CCS to turn over all of those patients, it was pretty easy to take care of it, and it ended up being a really good line of business. Since then, we've changed to an MSO, and we have right now we have 6 small groups. Our newest group is going to be very big in Medi-Cal very soon. It's an FQHC system, so we're going to see a lot of stuff coming in. We specialize in the niche clients with custom needs. As James said, my undergrad degree was in anthropology, so I kind of started out understanding that healthcare isn't the same to somebody who got here from Korea and somebody who came from Central or South America, and so it was just sort of part of my just inner feelings about it that we had to create what we were doing in a way to make the doctors and the patients feel comfortable with what their healthcare was. We do startups, so we've done, especially lately, we've done a lot of startups and groups who want to do the duals. And that's been driving everything, it seems like. Everybody wants to be CalMedi Connect or something, because we do have a lot of Cinderellas. I love that. Everybody's dancing and they're not heading towards the door. I'm trying really hard to push them to the door. We also have sort of like geographic, not anything like what they've got. We have a few counties, but we try to make sure that where we are, our way of providing the services to the client, works for where we are. And we have a client who's just coming up with a limited knox team, like in this many days, maybe, something like that, It's a long process, and we've been working hard with them. And I think that's going to be an interesting part of our journey as we move forward. We've also been a fiscal intermediary, and that was another interesting thing, because until December 31st of last year, there were 65,000 MSI patients, which were part of the low-income health plan in Orange County. January 1st, there was 0 because the Medi-Cal expansion flipped them all into there. And these were the patients who were probably the sickest and have the most demand for care. In managed care, you've got the commercial patient. The senior patient is usually thought of as like 3 and using resources, and these guys were like 5. So it's going to be an interesting journey to see how those patients get taken care of under the Medi-Cal system. We had set up like medical home systems for them, but it was so hard to find them because there were so many who were homeless or almost homeless. So this is all going to be a big struggle. We also have custodial, which are the most interesting medical records, and some public health. And we also do contracted claims processing for health plans. We've done overflow for health plans as they've changed their software so that they can keep up with what they need to do. And we have a commercial ECO demonstration that we're working on, and we also do dual risk with hospitals. Now we get to go to Khaleesi.
So I should have known when James asked me to speak that he put me up here. I don't even know who that character is. So whatever I am supposed to represent today, I'm glad I wasn't the head on the spear. Thank you, James. I appreciate that. So I'm going to talk a little bit more about direction and what we've learned as we've gone out across the country. My education in California has been so valuable, and we've been really fortunate to be able to take some of what we've learned in terms of managing populations and aligning physicians and take it to other parts of the country. We have a couple of defining principles in our vision that we think, regardless of where you are, when you're trying to solve for the future state of healthcare, you need to bear in mind. And one, we're really looking at technology and services in terms of transforming delivery, but keeping the physicians whole. And what we mean by that is there's been so much pressure on physicians to take all the burden of defining quality, doing the administrative work around quality, medical-centric home, all these changes coming down to the primary care physician. What can we solve for with technology and supportive services that we can put around physicians so that they can continue to practice medicine and move forward in the new paradigm? The second thing is really being able to understand how to engage individuals in the way that they want to be engaged. So regardless of whether you're commercial or senior or Medicaid or whatever your ethnicity is, who are you as an individual? How do you need to access care? How do you think about health and wellness? And really going beyond what is clinical and adding in psychosocial and economic factors that may all play into how you're engaging the healthcare system. Not too bad. So just to kind of give you a feel, as you know, Medicaid, in terms of how it's delivered and regulated, it's very different. It's state by state across the country. And we have quite a strong presence. We're yellow and orange dots on this map. Quite a strong presence on the seaboards. So if you think about California and also Arizona, very advanced in the way they've approached the Medi-Cal population and Medicaid population. Slightly different, but both population health based. If you get out on the eastern seaboard, particularly in the Northeast, there's a much different approach, very unmanaged traditionally. But if anyone wants a good career in the Northeast, the state of New York just allocated $6.5 billion to the delivery systems, hospitals and physicians alignment, purely around transforming how the delivery system will work in the future with 4 domains: data, population health, disease-specific programs, and financial risk management. So if any of you want a new career, there's a lot of money in New York waiting for you right now. But you see that all over the place. Another place that we're doing quite a bit of work is in the Midwest, where a lot of the unions exist. Unions have been very forward-thinking about population health, and they've also parlayed, because they do a lot of the government employees, parlayed their talent around population health into some of the very sickest populations. So what we would call Mr. Mid in the past is centralized in a lot of the benefit administrators in the Midwest. So we've been working with that group. We do have about 4 million lives across our client base and about $17 billion in annual spend. Thank you, California, for teaching us how to do this. We've enjoyed teaching other people. So we look at our client base really in 3 sectors now, so 3 stakeholders in the healthcare system, all coming together to solve if we're doing this holistically. And if you think about employers, but loosely defined, employers are really purchasers. So whether it's a government program like Medicaid, local program for Medicare, or an actual employer, that purchasing group has particular talent around how you structure a benefit so that people will engage and act in a certain way. So when we're approaching the Medicaid population, one of the things that I think we're starting to see more flexibility around is how do we structure benefits so that people behave and access care in a way that makes the best sense for their wellness and the best economic sense for the system. The second thing is we do provide quite a bit of services and infrastructure for health plans. And where can health plans really add value that we may not see as providers? They understand members, not just patients, but members, because remember, a big part of what they're trying to do is get all the healthy people. So how do people who are healthy act? What can we learn about engaging them so that we can help the people that are at risk or people that are sick get better behaviors going forward? And again, that's not just clinical information. So that's bringing in a lot of social information, economic information, commercially available information about individuals. And then finally, we're seeing more and more that California is very unique in that you've got the corporate practice of medicine, so it doesn't surprise me that there aren't a lot of hospitals in here and that you see a lot more physicians. But around the country, it really is about health systems, the entire care continuum, coming together to take on risk at the same time. And because they're later to the game, they're solving it, I think, in a more holistic way more quickly than we did in California. It took us a while to get to a place where we were all working together. But I would encourage you to watch other parts of the country because they're moving really quickly and doing some very innovative stuff. So with regard to all populations, but probably even more important than Medicaid than anywhere else, focusing in where you can have impact. So there's a tendency, I think, when you begin in population health, these populations are strapped. We have to focus the resources where we know we can have the most impact. Of course, that will always be around the complex cases, but it's also getting in front of chronic disease, getting in front of the access issues, removing the barriers that aren't traditionally barriers that we would think as being the clinical piece, but getting the ramps built so people can get in and out of their house, making sure that someone who is supposed to be getting bathed is actually getting bathed. And how do we solve for those things so that we can make sure that this very frail population and at-risk population is truly being served both clinically and socially? And then if you can figure out how to credential the ramp builder, I've got a really good job for you because it's going to be a big challenge for us going forward. So the last thing I would say is just, in some ways, the markets that come to population health later are advantaged because they're investing now in their infrastructure around IT. And it's very hard when you've invested in IT infrastructure and you've been doing it for 10 years to go through wholesale replacement. But if you're not going in and really getting your data warehousing right, your risk stratification, your predictive modeling so that you can focus, and then also really understanding outcomes at the provider level so that you can look at the cost-quality outcome relationship, it's going to be hard to stay ahead of the population health curve. Yeah.
All right, great. Thank you so much. I have to remark, 10 years ago, if we had a very similar conversation, a lot of these things wouldn't be mentioned at all because technology has literally leapt in the last 10 years so far. And there are big healthcare systems that you're right, they're committed to year 2000 technology. And the keys to winning are going to be that identification. So it's really amazing to hear both of you guys, what you guys are doing. What a wonderful perspective. SynerMed, we look at ourselves as providing things for plans and physicians and patients. For plans, we're providing them low-cost, high-quality networks, networks that can achieve the best quality scores, even for the Medi-Cal population, which for the longest time has been my mission. A big part of the reason why I joined this trade association and looked up to a lot of the folks that made a big difference in all these other populations like commercial and senior was that there should be no reason why just because you're on Medicaid that you can't get the same kind of quality scores as somebody in commercial or Medicare. And you know, we're making it happen. And I'm really proud of the efforts of all the folks in the Medi-Cal subcommittee and what they've done in the last few years. It's just been really tremendous. And as well as the trade association for supporting these types of continued improvement processes. For physicians, we're really trying to help them deal with a really poorly subsidized and poorly funded system. You can't make it on Medi-Cal. Medi-Cal fee schedule is horrible, so you by necessity have to innovate. And fortunately for us here in California, we were out of the gate early, and so we did things, and so we got into population health to help a doctor manage maybe the 200 patients they need to focus their attention on while they're being assigned 2,000 patients. And so then the math can work out and we can attract high-quality physicians to treat the Medi-Cal population. And then the patients, we want to give them choice, and we want to give them quality, and we want to give them a team approach to medicine, things that they weren't used to in the past. And that's what we do. We have about 800,000 members. Our management's growing significantly. I really don't know what it's going to end up after the Medicaid expansion. I think there's a 900,000 member backlog in the Department of Social Services right now. So everybody in this business is going to get a lot bigger, and that scares those that have been in this business long enough. What that means, we're pretty much in almost every market in the state of California, except for the Bay Area and some other esoteric communities like what are some of the other counties that we're not in, and then we're in every single product with about $500 million to spend. For us, the technology is a real key. We were fortunate to be able to spend a lot of our capital in the development of a web-based environment for our physicians and our patients, and so we put a lot into that. You know, some people call that the Internet of Everything. I think that's an HP traded mark thing, so we'll call the Internet of Everything / healthcare. And what we're trying to do is add additional applications so that whether you're a medical director and you're remote and are part of a team, you can still connect into a system and be an effective medical director. Whether you're a specialist and not available in a community, you can link into an e-consult platform and provide some sort of curbside consult to a physician in a rural and remote community, and et cetera. So we're really looking at building those building blocks so that we can create a scalable and an effective platform. So that's commercial, all right? So the commercial's over. I think it's probably fair to say that no matter what you do, if you're working with my colleagues here, you're going to do very well for yourself. I think there's a lot to be learned. But that's not really what we're really concerned about, because winter is coming, and this is kind of what it looks like if you watch the show. Earlier on, we were talking about, or Kathy was talking about the TANF population, or the treatment to needy families and pregnant mothers, and it was fairly simple. Pediatric care, carve out with CCS, not a lot of pathology, all the things that Megan was talking about, which is amazing that we're all talking about behavioral health and substance abuse and near homelessness and all these community supports. It's really kind of exciting because that's where it's going. It really is. And so we were plugging along, trying to do what we're doing with this population, and then the state said, hey, it's time to move the seniors and people with disabilities into Medicaid managed care, and I think it hit the whole industry pretty hard in the chin. I know it hit us pretty hard in the chin, hit all of our clients, hit all of our health plans, our physicians. This population has significant needs, and they need to be risk adjusted or identified or classified and provide different kinds of services for them. And then on top of that, not very long after the SPD rollout, we're moving right into Covered California. And for those that are, who in the room has participated in Covered California as an at-risk player? As an at-risk player? Okay, so we got one at-risk player, right? Thank you, Ultimate. For us, we chose not to participate because it didn't fit into our business model. But then one of the amazing things is that a lot of people went to covered California and realized that they were eligible for Medi-Cal benefits. And that's a great benefit design for really low cost. So I think that's the reason why there's a 900,000 member backlog in DPSS. And then now, just starting in January, we've had the Medicaid expansion through the Affordable Care Act. And I think for the most part, it's the TLIC population that's come in, and we'll expect some of the other populations coming in later. But we really don't know a lot about this population. There's guesses as to what to expect as far as their particular pathology and whether the dollars associated with it from the state to the plans to us, and we're going to make it work. And the same thing goes with the Cal Medi-Connect, which is, depending on which county you're in, is already effective. We have operations in San Diego already have members, operations in San Bernardino already have members, and LA, I believe the health plans are already getting data from the state saying, you got members, get ready. So it's coming. So what did we learn about SPDs? And I'm going to give it an opportunity. So if I don't cover something, Megan, Kathy, you can always come in here. But what we definitely discovered was the SPDs that we were tracking even before the implementation were less sick than the population that came in after the implementation, significantly. Okay, we found that there was pent-up utilization. They just didn't have access that you thought would be in a fee-for-service environment. So that pent-up utilization affected a lot of the risk-bearing entities. And what we're finding is a significant amount of dual and tri-diagnosis. So dual being behavioral health and your chronics, and then tri being behavioral health, substance abuse, and your chronics. So, real combinations of care models that have become really complicated for our networks to manage. And then this real issue of homelessness and near homelessness. So the lack of community supports, lack of family supports that really affect what's going on. And so it's encouraging to hear my colleagues, who I know are doing great things all over the place, to be echoing and being on top of these things, because we're finding it to be truly critical in really helping manage this population. So, we're also finding there's massive gaps in care, right? So this population doesn't always seek care through the traditional primary care physician. And the system is designed to assign them to a primary care physician. And so that creates gaps in care that we need to find ways to fill. So a lot of us have created different types of care models. I know we created an ambulatory ICU. Is anybody else experimenting with chronic care clinics or ambulatory ICUs in the room? Well, if you're not, I highly encourage it. I encourage those big hospital systems that are going to move into risk. It's a model to go to really reduce the overall cost of care, and really just manage these things that are just not necessarily manageable in the old system. Because just like the technology is advancing, the whole process of fee-for-service medicine, CPT codes, and things like that may not be coded in this other environment of behavioral health and substance abuse and respite care and caregiving and the like, really need to be filled for us to be successful. And then on the SPDs, lastly, is the risk that you're getting really supported by the revenue. And this goes between you and the plan. This goes between the plan and the state. And I can tell you that our subcommittee and the Medi-Cal subcommittee is very much in tune with this, because we're very concerned about the groups that may not be funded properly, or the plans that may not be funded properly by the state. So there's going to be a lot of dialogue. I think you're going to hear more and more about this kind of environment. A necessity, a risk does kind of create a necessity to innovate, but at some point, you really got to make sure that the funding's there. And then the managed care expansion populations, or sometimes people use this acronym, MCEs. I think somebody was talking about their disdain for acronyms, but we love to use them in this business. So, you know, they're divided up in these two populations, the L1s and the M1s, and that's their aid code. So, so for those that are doing the analytics, so you can track to make sure that you're being paid appropriately, or at least know what you're not, you know, what they're costing you, etc. The L1s are the ones that we saw a big push in the beginning of the year, and the M1s are really that 138 population, that ACA expansion population that you're going to see trickle into our groups and our networks in the coming months and years. So I was hoping when I was putting this slide together that we'd actually know something about this population. I think the drum beats are coming.
Oh yeah.
The others are coming.
Wednesday.
Yep.
All right. I wish we'd known. Yeah. May start running quickly. We were hoping to know a lot more at this point. As you know, when new populations come into a risk model, there's a lot of disruption in the payer and who's a payer, and so those that are very much involved in your IBNR calculations, be conservative. It will take longer than you think for it all to run out, and so we're seeing a significant uptick in the most recent months. We still haven't got our fingers to say whether or not the reimbursement is appropriate or not. There's sort of a consensus that it's been funded well and much better than the SPD population, but I've learned to temper my enthusiasm for such type of prediction. So we're going to continue to be monitoring it, and we'll be talking to our plan partners about that as well as the state as we share this information going forward. And then lastly, the duals, which I think has gotten a lot of attention, particularly by those that have been in the Medicare Advantage forever, and realizing that this is another very large wave of revenue and expense and the like for the delivery system. This population is characterized by even more high costs, even more high needs, elderly obviously. 55% of this population is going to have 3 chronics. So again, the groups involved in this are now having to continually evolve themselves and prepare themselves for these different populations. That means a different model, right? It means different components that need to be added to it. 1 in 6 live in an institution, and they're not always what you think they are. There's different cohorts of population. There's the little old lady from Pasadena who is a Medi-Medi, and she has actually lots of resources. Somebody's paying, taking care of the assisted living facility, but they're a Medi-Medi. And then there's a whole different population that might be that near homeless person or homeless person that is also a dual, and they're duals for other reasons. And so you're going to see a real wake-up call when people get some of this population assigned to them, and they're not risk adjusting them properly or stratifying them and getting them into a care model that's going to be effective for them. And the old model actually is pretty fragmented, confusing, and inefficient. You've got hospitals that have lived off of the admission of SNF members at their facility, and there are some great examples of members of this trade association really have found ways of creating great care models in the SNF environment. They really need to be copied. For those that have not already got a SNF program or a SNFist environment or 24-hour hospitalization management with a doctor, these are the kind of things that can be copied and emulated. Healthcare Partners has got a great model. Kaiser's got a great model, and so definitely I encourage everybody to look into it. But we're dealing with even a few other things that most people, if you're not in the CAPG space, wouldn't know too much about, right? So in-home supportive services, and in parts of Los Angeles County, you're dealing with SEIU ULTCW, right? We're one of the largest unions in the country that provides caregiver services to Medi-Medis in their home. And there's some real interesting things there. CBAS, which I guess is the new name for adult daycare centers, that's had a transformative effect on the networks. I know our friends from Ultimate have had to make lots of adjustments to make that system work properly. MSSP reminds me of my old days at Scan Health Plan. I think we ran an MSSP site in Long Beach. This is called a multi-purpose senior service program, really in the vanguard early on, providing sort of scan-like benefits, in-home supportive services benefits for dual eligibles, but on a sort of a grant-funded, static, waiver-funded type model. Not really scalable, but really some amazing things are going on there. So I really encourage folks that are trying to solve these problems. They're great resources, but just realize they're not-for-profits that were very mission-oriented, but not necessarily ready for 250,000 tools all at once, right? So be patient. And then there's also the program from All-Inclusive Care for the elderly, which is PACE, which is an amazing program built around the adult daycare model, and then providing really a patient-centered medical home for some of the more frail senior population. Really an interesting model. I think Unlock was the first one to do it. We're here up in San Francisco. They're great. Ultimate's got some clinics here in Los Angeles County for those that are interested. I think it's starting to expand around the country too. I don't know if you're seeing that, Megan, in other states, but yeah. So it's definitely an interesting model to take a look at. Now the duals demo is supposed to be in Alameda, Los Angeles, Orange, San Diego, San Mateo. People opting out of the system. They don't have to be part of the Cal MediConnect program. They can opt out their Medicare, but what they can't do is opt out their Medicaid. So, and the plans are still trying to figure out how that's all going to play itself out, whether the Medicaid is going to be coordinated with some of the risk-bearing entities, how that's going to play itself out is really still to be determined. So, with all that said, I'm going to open it up to questions.
First, thank you for your presentation and insight to organizations. I was curious how the organizations kept pace or worked to anticipate the increased use of quality metrics and the potential impact of funding by more and more state programs.
Okay, I can talk about that. Can y'all hear me okay?
Yeah.
So that is a really salient issue all over the country with all programs, not just Medicaid. I think what I've seen be really successful is when the physicians take a leadership role around and taking control of how you're defining your measures. So if you leave yourself in a position where someone is constantly telling you whether or not you're meeting your quality metrics, you're really disadvantaged. It is well worth the investment, and it's not that much investment, to make sure that you have your own data warehousing, your own HEDIS analytics, and really make that part of your culture within your practice, is to get your data right so that you represent the quality of your practice appropriately. In terms of the funding and the what that does to the economics of the practice, this is a reality. The train has left the station, so get ready by getting your warehouse in place and your ability to track the data. And then you really have to look at this as an opportunity to put your value proposition out to the marketplace. So just meeting HEDIS is one thing that says you also ran, but if you can start to create quality programs and look at this action drove this outcome in a way that's innovative to your population and your practice, I think that's where the real leadership will come. And we are seeing, if you look around the country, we're seeing people begin to negotiate on a value proposition that shows better outcome, always lower cost. And you can turn that into something that's productized. So now you can go to the marketplace and say, I can prove quality, I can prove cost. That's it. It's something you have to take hold of from the physician perspective.
And one of the things that we've found is you want to treat it all the same when it gets to the provider office. You don't want to say, okay, this patient is a Medi-Cal patient, this patient is a dual patient, this is a, Medicare Advantage, whatever. They're just, one of the patients of the group. They've all got to be treated the same. Our data warehouse gathers them all up no matter what. And yeah, it's being ahead of the game and making sure that we've got it in there, before, we look at it before the plan does, before CMS or the state get a chance to look at it, because you really want to know where you're coming from and get past where you need to go, or it's already too late. You've got to just keep reaching for that and getting in there and doing it. And the provider education is really tough. I mean, like one of the issues that we've had is the disease management, outpatient case management, whatever you want to call it. We try to do the same thing for some of these Medi-Cal expansion patients, and it's really, really difficult. You know, managing those is really difficult because just finding them. You know, I mean, it's always been a little difficult to find a Medi-Cal patient, but some of these that have been in the low-income health plan and were homeless or almost homeless, where do you find them? You know, so we're trying to come up with better ways to locate them when they're at the medical home, or come up with almost like a case management clinic type of thing where we know where they're going to be so somebody can talk to them. But it's all trying to get ahead of the game, because it's just become more and more difficult just to do the day-to-day things that we're supposed to do to fill in the little check boxes.
Hello? Yeah. Can you go over again the dual eligibles, what their choices are in terms of Medi-Cal or Medi-Cal managed? So is that happening now or January 1? Or
what community you operated in?
San Diego.
All right, so San Diego, I believe, started in May. Paul Hernandez, you're in the May sound right?
Yes, May 1st relative to April 1. Right. And that is with rail eligibility. So there's about 4,000
Is my birthday or something that goes so much per month, or they're all?
Yeah, so the way that I understand it, and Paul, please, you can hop on the mic and clarify if necessary, but it's, you don't have to. Wait till I blow it, then you can come. I won't put you on the spot like that. But basically, yeah, you're right. It's based on your month of your birth, and it's gonna roll in over a period of a year. And there was a slight delay in San Diego County. From what we were hoping for is to get a lot of data for this population before it got enrolled in. We haven't gotten any of that data. So, and we have some other challenges, right? So we want the data. We want to be able, that data would be really nice so we could stratify them really quickly. And then we also have these challenges that Medicare and the plans, obviously, are requiring an individualized care plan for every single member, which is great in concept or great to say, but really difficult to do, and sometimes maybe a little silly when you really want to focus and stratify your population as quickly as possible and make sure you're allocating your very scarce resources of the activities of your organization. Yeah, James.
Good afternoon. So I have a question for you about innovation in that particular environment and serving a population that many of us haven't done from a managed care perspective. It turns into charity care and how do we take care of our communities. Have you looked at anything along the lines of, is it cost effective and good quality care to do mobile clinics, outreach into schools, what about going to churches, those types of things?
Some of those examples you mentioned, we haven't, but we've done some things that have been pretty exciting. So, and I'm going to let the other folks, I'm sure they're doing very similar things and different things, but I'll give you a couple examples. Our San Diego operation operates a CMS innovation pilot called Hotspotting, which is really based on Dr. Jeffrey Brenner's work out of Camden, New Jersey. And it's been, I think the results came back 6-to-1 return on the investment, Paul. And that's really just really filling in these gaps of the care for this population, really creating a different kind of care model that's outside of the standard way of doing things. We've also are involved in a innovation pilot with IHSS here in LA County, which is trying to help these IHSS workers become care navigators by interacting with them, the patients, and providing us feedback using different tools rather than dialing 911. We've also been able to do some ambulatory ICU work, which again has been pretty exciting. We've created a complex care center in downtown Los Angeles to focus on our sickest 1% of the population. We're still working on the data on that. We believe it's at least 6-to-1 return on investment, but we have to, we've got some statisticians looking at it, so we don't give ourselves too much credit for it, because we really are trying to find a way to eventually turn to the health plans and turn to regulators and say, you know what, if we can risk stratify this population, they're reliably worth $20,000 a month for a case rate or something. So we're trying to bring it down so that we can create different types of models. But you bring up some really amazing things, which is like food banks and other types of community agencies, and every single one of those, which we haven't gotten to yet, but each one of those are opportunities for, I believe, learning and innovation. So for those that are thinking along those lines, I'm really encouraged.
Okay. So yes, we see incredible innovation all over the country, and it looks really different depending on the community that is we're attempting to serve, what types of resources are there, and how does the community act. Even things like weather play a factor in terms of where people congregate. But some just high-level examples. So in a given community, where are people going? In Detroit, there's been some amazing success with projects where we put nurse case managers in the churches on Sundays, because everybody goes to church, a strong sense of community there. So bringing access to primary medical information to a place that's very unthreatening and familiar and safe. Excellent collaboration between the YMCAs in some cities, again, where people are going for services, so just bringing clinical to that setting. We're seeing much more willingness on the part of traditional retail or community-based services organizations to partner with the clinical piece in a way they never have before. Nurses can be the right person to put in the community, but sometimes even that can be a little threatening. So it's also understanding who do people want to talk to about their health in a given community and resourcing for that. So this is more primary care, as opposed to, I think James touched on some really great, more acute or disease management strategies, but engaging people prior to their episodes or acute episodes is really critical.
One of the things that I think is going to work out best, it's just really starting up now, is an FQHC system that we're working with, and they have so many services available in the clinic, and because there's more than one, they've got the patients have the ability to go to whatever clinic has the service available at that time that they want, and there's social workers that are part of that. There's nutritionists. They've got county mental health workers with offices right there within the clinic, so they're able to really consolidate. And they've got a pharmacist. You know, it's really like a full service thing. And the patients were already there. They just changed from fee-for-service Medi-Cal to managed Medi-Cal, if you want to call it that. And so it's more changing the mindset of the providers than it is of the patients, because they're used to coming. But they've added a 24-hour nurse hotline. They've added extra lab services, extra imaging services, things like that. So they're going to be able to get so much done at their medical home that I think that in the long run, it's going to go a long way to making sure that their needs are met without having to send them out for other services. It's going to be, in the long run, almost managing itself if they keep in line with their mission. So, like I said, it's too early to tell because they're just really getting started on this because of the rural expansion. So, but I really have high hopes that this is going to be one of the areas where there's really going to be a difference, and that'll be not only for the Medi-Cal expansion, but for any Medi-Medis. It's not a dual demonstration county, but they've got lots of Medi-Medis, and I think in the long run, it's going to make a big difference. And since it's an FQHC, they figure any profits that they can make, they can dump it back into services for the community. So just keep adding things that they can do. So, I'm hoping that this is going to be like next year we can talk about this as, our big, superstar project kind of thing. But, I think it's a good start.
Two questions for you, both financially involved. One is the retro SPD money that was distributed. The plant said, we don't have enough. They got some more money. Just has it passed downstream? Has everybody gotten that? And then maybe also some thoughts on how the ACA bump maybe goes into the calculus of what you're doing and how those funds are being used today.
So I'm going to go first because it's like, obviously, this will give them, they can always say, well, I'm not going to comment. But I don't think a single client of ours got SPD dollars retro. Now, they may have been paid, we may have been lucky enough to negotiate our contracts ahead of time to know that SPD rates need to be significantly more than our other contracts, and we may have been fortunate enough that helped our clients, but none of our clients received any SPD retro dollars. And our position on the ACA bump is the data that we're getting from the plans is so poor and the attestation is so scary, and since I don't look good in orange, I won't touch the money. So what's happened is the dollars that went from the feds to the state to the plans, and then what they want to pass down are some pretty scary things. They are federal dollars, folks, and so we just want those dollars to go directly to the doctors, and we want them to get made up with whatever those dollars are, but we do not want to attest that it's accurate or that it's appropriate or what have you, because we weren't part of the discussion between the state of California and the feds, nor the one between the state of California and the plan. So that's been our position.
Ditto.
Part of our success has been having a diverse payer base. So those of us that do Medicaid, it's having commercial, senior, and they're doing all those really well. What I've seen over the last couple of years is the health plans allowing some groups to cherry pick. So where some groups will say, hey, I really like the senior line of business, but I don't like doing Medi-Cal, so let me suck up all the seniors and let all these bottom feeders do the Medi-Cal. And so what is CAPG's perspective? Has this committee got CAPG behind the Medi-Cal groups here to put some pressure on the health plans to say, hey, you groups that are cherry picking and taking just the best paying lines of business and decide to not care about the Medicaid populations, that's not really best for our communities.
I really appreciate Remy making this a little bit more interesting. and I'm going to pass it to the chair of the Medi-Cal subcommittee.
How nice of you. Actually, I have a few groups that are the cherry pickers. And you've got to understand something. We have groups that are capable of seeing Medi-Cal business as a whole with, pediatricians, with pediatric subspecialties, things like that. There are some groups that put themselves together to focus on seniors. And those groups just wouldn't be able to take Medi-Cal. They wouldn't be able to provide the services. They usually don't end up being large groups. They stay pretty small, but pretty local. So, and I don't think it's because they consider the patients bottom feeders or anything like that, but it's the traditional makeup of the practices who are in these groups, they probably wouldn't really be able to do the right services for Medi-Cal populations. I personally like working with groups that take Medi-Cal, but I want them to be able to do the right services and that we can help them make sure that everything's set in place to take care of the patient right and to not lose a bunch of money so that, you know, they have to go out of business and then, you know, leave the patients without their normal system of care. Fortunately, I guess it's not something that's forced. There are some health plans that really don't want to contract with a group unless you take the full range of products. There are others who maybe only have senior, so that sort of limits it somewhat too. But there's got to be some that take Medi-Cal and some that don't, just like any other practice pattern.
So I want to add something to that, Remy. It was a big battle for us for about 3 years. I think it's starting to ease a little bit. But even if you stay outside of Medicare versus Medicaid, within the Medicaid delivery system, we have cherry picking. We have people who narrow networks to make it much less internal medicine focused, people who narrow their OB panels. These are the patients that are all in the actuarial model, so it becomes incumbent on us for those who have clients like yourselves that are serving the community holistically to really stay on top of what's the appropriate funding and to be working with the plans really closely on that so that it stays balanced. Okay, if you're the only one who's taking those internal medicine patients, let's make sure that we're making a really articulate argument about the risk of your population and getting you the right funding. And hopefully the plans will do their work around making sure that network is balanced as well.
I think you really bring up the real key piece, right? And you can have all the innovation in the world, and we're all striving for it. And I'm really impressed with really how far and fast we've come. To be honest with you, we really this group of groups of Medicaid groups have really done some amazing things. But eventually, it does come down to getting proper funding for the population you're serving, and not eventually. Yeah. Well, the thing is that what's happened is the reform has hit us in waves, and I can tell you, we like to say that we're on the front of everything, but we're still paying catch up because SPDs happen, the MCEs are happening, the duals are happening. It's all, as you say, the train is left, and we're trying through the subcommittee and other efforts to engage the state of California and both the different departments that are involved in this, whether it's the Department of Managed Care or DHCS, to express these issues, whether that's the Financial Solvency Board. We don't want to see, which I fear, actually, I think it's very possible that with the SPD, the MCE, the duals, that you could see a rash of financially insolvent groups like we haven't seen before. Not just 1 year, but 20 all at once. And that will be incredibly disruptive to the overall system. And I think we all kind of have to really articulate conversations and honest conversations about those things. So I appreciate the question. I think it's a good question.
Right. But it is sort of it takes the whole system-wide thing off balance when we have groups starting to, go under, because then everybody else has to struggle to make up for that, and there's, sometimes you have such a hard time with continuity of care and, all of these other issues. So if there's a group and they're working, it's probably best to try to make sure that they can at least stay, along a path and not tank, because then it is a problem for everyone else in the same community.
Any other questions?
Nobody wants to beat us up. That's why we brought James.
It is, for some of us, it is cocktail hour.
Just a simple question. What's the insight about data exchange? You know, as the duals or the Medicaid beneficiaries can hop around different health plans and groups in getting the data to us, and how, yeah, I know. So how do we prove that, and how do we solve that, and how do we get that to help us?
I haven't figured it out.
No clue.
I have no clue.
I was just talking a dual demonstration CEO the other evening, and I said, how do you feel about the data coming from the state? And it was sort of like, it's, you don't trust it, even if you get it, and a lot of it hasn't even been received yet. So it's going to be a big problem.
You even remember, right, the SPD data that we did get, if we did get it, right? It was a risk assessment that was done, and it would be so distilled down by the time we would get it, it would say something like cancer. And not what type of cancer, not when, not whether, it would just say somewhere in the claims history, cancer, and that would be it. And so it really became useless. And this is what concerns me about sometimes, through the rush to reform, right, which I appreciate. I think the system needs to be reformed, but sometimes we put these prophylactics of check boxes of, we'll do an individualized care plan, and that's going to solve everything. Or we're going to do a risk assessment by a third party, which data we won't share, and that'll solve a problem. It really doesn't. It really takes a team. Everybody needs to be working together, the plan, the hospitals, the groups, the doctors, the primary cares, the specialists. It's a combination of back and forth that really needs to be well-oiled.
So Mark is on my team, so full disclosure. I think you have to have a really strong team that knows how to deal with data, like the one you run, Mark. So, question, I asked you the question when you're going to solve it. But the data is a challenge all over the industry. The Medicare data was really challenging. We had multiple iterations of that, clawbacks on the data. I think for the Medi-Cal committee and all of CAPG, a real good takeaway would be a common voice on the challenges we're having and what we need from a data set perspective also.
Yeah, agreed. Okay.
Hi, I just have a really quick question. The medical groups that you work with, what type of prep work is everyone doing to prepare to take care of the institutionalized duals?
So I think the question that she asked, and I'll try to restate it, but was what kind of preparation are some of our clients doing to prepare for the institutionalized duals? So those duals that will be assigned to the Cal Medi-Connect program, that will be those 1 of 6 that will be in an institutionalized setting.
So I'll start with, I'm going to start on the end of what we're doing to try and make sure that less people are institutionalized. So there's a lot of partnerships with SNFs and some of the larger firms around the country that are trying to move their business to the most acute part of SNF or institutionalization, and really look at ways that some of the other types of deficits can be served in the community. So what can you do, back to what I was talking about, in terms of if a service is administered in a home, how can you use technology or other types of oversight to make sure that you're able to monitor that patient in that setting and you're able to monitor the caregiver. And when you think about it, obviously, our patients in the Medicaid population oftentimes don't have a whole lot of technology, but everyone's got a phone. And so there's a lot of talk right now about how the cell phone, and you can get a real-time understanding of what's going on with the patient when they're there to actually speak to you. How can we expand the clinical care team into the home through the use of phones and monitoring and oversight? And I'll let you go to the Q.
I'll try, and then we'll just keep on going. Because this is a vast program. I mean, a vast problem and a problematic issue. Sometimes it's referred to long-term supportive services, and it includes a lot of those things that were listed up there: PACE, MSSP, adult day care, board and care facilities, skilled nursing facilities, assisted living facilities. What we know is that there's some populations that's not going to leave an institutionalized setting. And so then it's a matter of managing them in the institutionalized setting and building up sort of the economies of scale within particular settings to manage them effectively. So that's those that you can't do anything with, in essence. They don't have the system, the home supports, the family supports, and home supportive services and the like to actually go home and the like. A lot of all of our activities are focusing really on that post-discharge side of it and creating SNFIS programs and really developing, following the leads of players like Healthcare Partners and Kaiser and the like on creating sort of these post-discharge clinical models that will provide for the dual eligibles as well. And it's really, it's intensive management of that population and then transitioning them from, you know, a skilled facility and into a home environment that's supportive and won't get them back into the hospital.
Right, and what I'm going to say is just sort of like tagging on along that. There's actually only two things, because there's going to be the patients who are already institutionalized now, and we have to use our case managers and our SNFists to figure out if there's any place else for those patients, because some of them just can't go anywhere else. Some of them would be homeless if they left, actually. Then there's the ones who we can move. We have to work hard at finding out where they can go and what kind of services they need, and you know, can they have the IHSS program help them once they get home? Do they have family support, whatever? But then there's the second wave, which are the ones that are being discharged from the hospital now, and hopefully we can figure out how to get them home without going anyplace else, because they tend to get stuck in some of these places as they leave, no matter how hard you try to move them quickly. So that's going to be like this real, you know, point of that's like our fulcrum point, I guess, of the case managers to make sure that we're getting those patients in the right place at the right time. Once they, well, we hope that we don't even get them admitted. You know, that's our real goal. You know, keep them out in the first place, but the post-discharge, to make sure that they've got all the services that they need when they leave, so they can go home, or to get them there as quick as possible. But it really takes a lot of effort. Our case management team has like doubled, you know, in the last 4 months, I guess, you know, because it's just taking so much more to deal with all of this.
I think we're done. Hey, thank you guys so much for your